overlapping amongst the trials? And if
Yeah.
so, how to delineate between them?
Yeah, I mean, there are only couple which are slightly overlapping, but you know, we will do, so the only ones that in my mind overlap are clear and timeless, slightly.
Very timeless, okay.
Clear and timeless slightly overlap.
Okay.
You know, so if we have options of enrolling in both, then our preference would be timeless only because those patients are less common.
Okay.
Clear has a broader inclusion criteria, so we'll get more patients who are eligible for clear than we'll get patients who are eligible for timeless. So we want to enroll the patient into the study with rarer patient availability than enrolling the study with more common patient availability, if that makes sense.
It does. Okay.
Okay, so we'll quickly go over this. Clear and Tesla and timeless numbers. Okay. So clear studies is, I think the Sherman, my partner Sherman said it best. He said clear is for people who have nothing else available to them. That's how I look at it.
Yep.
Okay, so let me go back to, I think you guys we've talked about, there's a core and then there's penumbra. Who knows what a core versus penumbra is? All right, Sherry.
Core is where the infarct occurs, the penumbra is the area around it that could become ischemic.
Okay, so can you expound upon that a little bit more?
Okay, so the core is the site of where the problem occurs, and the penumbra is, if there's no reperfusion to the area, or perfusion is not allowed, then it's going to cause dead tissue.
Okay,
Yes, no?
okay. Yeah, so let me
Okay.
help you elucidate a little
Okay.
bit more. Core is the tissue that's already infarcted and it's
Yes.
irreversible. That's not coming back.
Yeah,
It's
okay.
gone.
I get it, yeah.
Penumbra is the tissue that's not gone yet, but could be gone permanently if we were not to rescue it.
Right.
Okay? Simply put, that's what core versus penumbra is.
Okay.
Okay? So, whenever the stroke occurs, you know, so let's say, I'm just gonna draw a brain tissue here. Okay, why is it wavy? I don't know, but it just looks wavy. And there's a blood vessel here. Okay. There's a blood vessel here that penetrates it. And there, you know, there are blood vessels on the outside and blood vessels going around it and so on and so forth. And let's say there's a clot here, okay? The area of the brain immediately surrounding the blood vessel will be infarcted, or it's gone, it's dead, it's irreversibly dead. It's not coming back, no matter what we do, all right? But as we go here, I don't want to get too much into it, otherwise we'll just spend the entire hour talking about this, but maybe it's worthwhile talking about it. So, all right, same tissue here again, okay? Blood vessel comes here, and then there's blood vessels going outside like this, there's blood vessels going outside like this, right? And the blood is flowing here, okay? You can imagine that this, right where the hose ends, so to speak, all right? There is the most amount of blood here. And as you go away from the hose, the amount of blood flow becomes less and less and less. There's a gradient of perfusion here. Yes, you guys follow that so far?
Yeah.
Right? So when here, the amount is the highest, and as we go further away from this, there's a gradient. So you would imagine that here, the contribution of this vessel up here is very little. But the way the nature designed it is that you have another blood vessel coming on the outside which supplies the brain tissue here. So there's a second circle here which belongs to this blood vessel here.
That would be your collateral then.
Yeah, correct, that's the collateral,
Okay.
right? So this thing is collateral to that, and this thing is collateral to that. They're interdependent on each other.
Mm-hmm.
Okay? Let's say we knock out this blood vessel here. Okay? There is this area where this blood vessel does not contribute much. Why? Because it's too far away from it. Right? So this area for sure will be dead because there is no blood supply to it whatsoever, which is gone. But this area here is not gone yet. Why? Because it has this blood vessel. So it's supplying this area just fine, and the gradient decreases, 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 and at some point here, there's very low blood flow. Low enough that the brain tissue does not work, but not high enough that it's not going to die, if that makes sense. Okay? So let me give you a very crude thing about thresholds of ischemia. Okay? And it's a very important thing to learn, actually. So this is blood flow, and on a scale of 0 to 100, and this is cc of blood flow, cerebral blood flow, per 100 grams of tissue. Okay, so if you're perfusing at 100, that means you're perfusing 100 cc's of blood plus per 100 grams of tissue. Does that make sense? Okay, if you're perfusing at 50, that means you're perfusing at 50 cc's of blood per 100 grams of tissue. If you're perfusing at 20, that means 20 cc's of blood per 100 grams of tissue, and so on and so forth. Clear? Okay, so these are somewhat arbitrary number, okay? These are close to, what we see in experiments, but these are not exactly those numbers, okay? Many of these numbers have been derived from monkeys, some have been derived from human studies, and so on and so forth, but these are invasive studies, so human studies are not always entirely possible, all right? But the original research that was done in the 70s, 80s, and 90s, these were mostly derived from monkey brains. So between 50 and 100, it is said that this is normal perfusion. Normal perfusion. Okay. Then this is what we call benign hypoperfusion. Benign hypoperfusion. And I'll explain what these mean in a minute. Then this is clinical failure, and this is electrical failure. Okay, so electrical failure. What does that even mean? So normal perfusion is that why does the brain need the blood? We've talked about it umpteen times. Why does the brain need the blood?
Our brain does everything for us. So our brain does everything for us, so
Yeah.
in order for us to function as an individual. we
Yeah,
have
but
to
what
have
does the brain need the blood for? What does it do with the blood? What does it derive from the blood?
Oxygen.
Oxygen,
And
what
glucose.
else? Oxygen, glucose.
Yeah.
Why does it need those?
Energy.
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 Energy to do
Yeah.
what? Energy to do what? Why do you need energy?
So we can be us.
Yeah,
But
yeah, that's the ultimate,
make
but-
it simple.
yeah, no, that's true, I agree with you, but I think it's more molecular level.
Okay,
The simple answer is for everything,
for everything, yeah.
right? If it wants to make proteins,
Mhm.
it needs energy. If it wants to make lipids, makes energy. If it wants to generate new cells, it needs energy. If it wants to repair old cells, it needs energy. If it needs to make CSF, it needs to conduct electrical, transmissions. If it needs to generate neurotransmitters. Everything you do, manufacturing, maintenance, upkeep, destruction, recycling, everything requires energy. All right, as I said earlier, no free lunch. What is the name of the Mr. Chicago economist who said that there is no free lunch? So the brain requires these things, right? So as you go down the perfusion, you have less and less energy to carry out functions. Okay, we know that this threshold it's called benign hypoperfusion because patients are symptomatic from it. But it's not entirely, we are not entirely sure that they're not symptomatic from it because at this point, the protein synthesis goes down.
Is this from age or when you have a stroke?
This is for any reason, your blood perfusion is going down. You have stenosis in the blood vessel, you have,
Does aging do this? Normal aging?
no,
Okay.
normal is a key word. Normal aging does not do that. Normal aging will not be, right? You see 95-year-old people, doing all kinds of stuff, active, driving their cars, playing bingo with their friends, solving Sudoku, completely fine, no problem whatsoever. Right? So just because you're 95 doesn't necessarily mean you're going to have hyperperfusion. Normal aging being the key word there. So protein synthesis goes down at this level between 50 to 20. Okay. Then you get what's called a clinical failure. What clinical failure means that there is no longer any neuronal transmission happening. Neuronal transmission. What does that mean? That neurons are not communicating with each other, right? Those neurotransmitters are not being secreted and accepted. Okay, there's electrical silence in that area. So will that be symptomatic or not symptomatic? Symptomatic, right? Symptomatic because patients are, come on in.
Come on and make yourself a plate.
So neuronal transmission is no longer happening. Patient will become symptomatic from it, right? So if you have hypoperfusion in the left frontal area, you'll be hemiparetic on the right side, right? If you had hypoperfusion in the Broca's area, you would have aphasia, right? So imagine this. Imagine this. You're a neurosurgeon. You have the brain cut open. You take a vascular loop around the MCA. Okay? So you have a blood vessel here supplying it. Okay? And you take a vascular loop. Right, this is not a vascular loop. And you cinch it and you tighten it.
Yeah.
Right? And you have an ultrasound probe of some sort which tells you the amount of flow in the vessels. Okay? And initially the value is 100. And you tighten the loop a little bit. The artery narrows somewhat. It goes down from 100 to 60. Okay? Brain's still fine. The patient's still able to talk. Patient able to do everything. It goes down from 60 to 30. Patient's still able to talk. Patient able to do everything. It goes down from 30 to 18. Now is the patient able to talk? No. Patient is not talking anymore. Okay? Because now it has dropped to that point where it can't compensate anymore. It is becoming symptomatic. Okay? But what has happened, even though the neuronal transmission has stopped, the brain cells are not destroyed yet. Because remember what we talked about before, we have talked about it many a times. What it requires for the brain cell to die is an electrical failure where the membrane gets destroyed. Remember that sodium influx that comes in? I can't get into it now because otherwise it'll take us 2 days to do this. Right? Sodium influx comes in, calcium influx comes in, there's fragmentation of the mitochondria, fragmentation of the DNA, the cell swelling, and eventually the cell ruptures and it's gone. Right? It goes into a process of self-killing known as apoptosis. Okay? That's triggered by that sequence of events. So at this point, the cell is condemned for death. It is so far damaged that it cannot recover itself and it will die. This is what the core is. Core is where the cell is going to die. It's gone. Right? This here is what the penumbra is. Okay? Where there is still reduced blood flow, but not to the point where cell is irreversibly dead. It still can be revived if we tried. Okay? So in a brain, that gradient looks different in different people and different areas of the brain, depending where you're looking and what kind of blood vessels that you're dealing with. For example, in a lacunar area, this gradient looks very different. In a cortical area, the blood vessels look very different. And the gradient looks very different. The posterior circulation versus anterior circulation, that looks very different, and so on and so forth. All right. In somebody, a young man, it would look very different than an old lady. Right. A black person will look very different than a white person, and so on and so forth. It has to do with genetics, other comorbid factors, a smoker versus non-smoker, whatever. Right. It's different for everybody. Therefore, we cannot predict in whom is it salvageable and in whom it is not salvageable. Hence the whole thing about perfusion scans, because we just don't know. You take two 65-year-old ladies, exact same demographic, okay? Let's say both white, both women, both from Northwest Indiana. Even in that very similar group, you will have difference of what the perfusion looks like and what the penumbra looks like and what the core looks like. Okay? So, so let me come back to the original question that we were asking, this clear study that we are conducting. These are the patients in whom there's a very large core. Okay, very large core is already there. And there's a way of knowing, and I'm not going to go into that either, but we can look at the CT scan and tell whether this is a large core or not, because there's a particular kind of scoring called aspect scoring that we do. And in aspect score, low number is bad, high number is good. So we are particularly targeting patients with low numbers in this thing. In previous studies which have been done, had been shown that people who had low aspect score, meaning a large core infarct, if we were to do thrombectomies on them, these people don't do well. Okay? So people started asking questions like, is it everybody doesn't do well, or is there some people who don't do well? So there has been some ambiguity as to what the answer is, and hence the study. If the answer was very clear, we wouldn't be doing the study. But there's ambiguity in it as to whether this is beneficial or not. So this particular study, the CLEAR study, is specifically targeted towards patients with large core. And here it says CTP core of 50 cc's. This is the exclusion criteria. So that means 50 cc's or more is what you're looking for. Yeah, you want? Go ahead.
Okay. So for aspect, Tesla has the low aspect.
Hi.
Clear has the higher aspect, right?
Yeah, sorry, I meant to talk
Yeah,
about Tesla,
we're doing
not
fine.
CLEAR.
Okay.
My
I'll call you
apologies.
if we need
That's
something.
okay.
Tesla is what I want to
Thank
talk
you.
about.
Okay,
The Tesla is for the people who we don't have any options for.
okay.
So Tesla study is where we have large core, low aspect score, meaning that there are already a lot of brain tissue that's dead.
Right,
And you want to see, well, can we help these people or not?
right.
You got it. Thanks for
Okay.
correcting me. So what we are doing for these patients come in, and there's an inclusion-exclusion criteria, and we look at their brain. Is this a large core or not a large core? Okay, and if it is a large core and they satisfy other requirements, we randomize these patients to medical treatment versus surgical treatment. All right, so half the patients we give medical treatment, half the patients we give surgical treatment. And then you might say, well, hold on a second, that's unfair. Why does not the other person not get a surgical treatment? Well, guess what? We already have that data. We did surgical treatment previously and they didn't do well. So we are not harming these patients by withholding surgical treatment. Okay? Because right now, what is our treatment paradigm? If somebody comes in with a low aspect score and a large core infarct, what do we do for them? Nothing.
Medical treatment.
Medical treatment, nothing. We don't do anything for them. So, in fact, there has been shown that just by the virtue of somebody being in a medical clinical trial, they get better treatment. Meaning that the medical treatment within the trial is better than the medical treatment outside the clinical trial, if you catch what I'm saying to you. All right? So somebody who's getting a medical treatment, quote unquote, in a clinical trial, still getting much better treatment than a person who is getting medical treatment outside the clinical trial. Because in a clinical trial, there's a heightened sense of checking the boxes, making sure everything is done, so that nothing is missed. It's protocolized, right? So you're following a specific protocols, and so you maximize the medical therapy and you don't miss anything. Whereas if you were to go to a regular small hospital where they're also doing medical management, they're not doing what we're doing for our patients.
That's
Even
true.
within medical management, they're not doing what we're doing for our patients, right? So, so I mean, there are other aspects to it, but forget it. So we are giving half these patients 100% of these patients would not have received thrombectomy, now half these patients are receiving thrombectomy, is the way I look at it. So it's ethically, medically justified of what you're doing. Yeah, go ahead.
Okay, and then, they'll utilize the data to say whether, it would be, okay to do a lower aspect. But like you and I were talking the other day, there's the reperfusion edema that you have to worry about
Correct.
then, and that would cause even more, possibility of bleeding and stuff like that.
That is correct, that's correct. So now what we're trying to look for here is two things. One, does it help? All right, so the possible answer to that question is yes, it helps, or no, it doesn't help. No, it doesn't help, book closed, end of story.
Yeah,
No, it doesn't help, end, done, everybody goes home.
yeah,
if the answer is yes, it helps, then the second question is going to be asked. Okay, well, two more questions are going to be asked. Who does it help? Is there a particular profile of patients, right?
Okay.
Patient above 80, patient lower than 70, men, women, blacks, whites, MCA occlusion, ICA occlusion. Who does it help?
Mhm.
If it helps, then who does it help?
Okay.
So then we can narrow down the population who it might help. And second question is, how much does it help? Just a little bit help or a lot of help? If it's a little bit help, maybe it's not worth, it's a long run for a short slide. We don't want all this stuff, right? You do all these things for what, like 2-point gain out of 100? We don't want that,
Okay,
right? So we want to know what is the magnitude of improvement that we're looking for.
okay.
So that's what we're trying to figure out here.
Okay.
Okay.
Yep.
So that's Tesla trial. Now this is, and I'm going to use air quotes. This is a real science trial, right? Because we're trying to answer real questions here, right? Think about the disease we don't know a whole lot about.
Right.
Clear trial is more of an industry-sponsored trial. It's a gimmicky trial. Gimmicky trial in the sense that it's a new device. We're trying out a new device. That's all we're doing. We're trying to figure out, is the device safe? Is the device effective? It is a thrombectomy device. It's supposedly a third generation thrombectomy device. So we are using their, anybody who is eligible for the study, would go in, and instead of using established devices, like Solitaire or Trevo, we use their device and try to pull the clot out and see how it does and what kind of clinical outcome the patient has. So there's not a whole lot to talk about there. It's just a whatever industry-sponsored trial. It pays well, so we do it. Timeless. Well, that's how people are going on the ISC meeting, right? Because of these trials. This is how we get the money. Timeless. So timeless trial is also a real deal science trial. Okay, what do I mean by real deal science trial? So everybody knows, or should know by now, that TPA timeline is 4.5 hours. Right? So TPA, we don't give more than 4.5 hours. So within 4.5 hours, and even 4.5 hours, like not in all patients. 3 hours is all patients. 3 to 4.5 hours, there's particular subsegment. Although we often flout those restrictions, and we still just give it to everybody within 4.5 hours. And then after that, we don't give it. So what we're trying to look for is that patients who have larger vessel occlusion, large LVOs, can we give them tenecteplase? By the way, people often ask me when I say over the phone, give TPA, and say, you mean tenecteplase? I'll have you know all that tenecteplase is a TPA. Right? Over the last 25 years, the industries have conditioned our brains to say TPA when you mean alteplase. Tenecteplase, alteplase, desmoteplase, pro-urokinase, these are all TPAs. Okay?
Yeah.
It's just TPA is a generic form, like atorvastatin, simvastatin, rosuvastatin, they're all statins, just like that. That's a category of meds. This is a category of meds. TPA is a category of meds. So tenecteplase is a TPA. Okay? Because I actually, so somebody wrote in the TPA was not given, tenecteplase was given or something. A nursing note said, TPA was not given, tenecteplase was given. Like, what does that mean? Okay, so okay, going back to the point, 4.5 hours. Beyond 4.5 hours, somebody has large vessel occlusion. Can we safely use tenecteplase and then perform a thrombectomy on these patients? That's the trial. Okay, so we are going up to 24 hours with LVOs, and these patients have to have a salvageable brain tissue. So we are doing those studies to figure out if there is a salvageable brain tissue or not. And so what additional we are doing here, so what is prior to this study, what would have been our paradigm of treatment? What we would have done is that we see a patient who is eligible for thrombectomy, we just take them to thrombectomy, done. So now what we're doing, we're additionally giving them TPA before we take them for a thrombectomy. So you might ask, why? Why are we doing that? What does additional thing imparted by, additional benefit imparted by tenecteplase versus no tenecteplase? And it has been shown that thrombectomy success rate goes high when you give somebody tenecteplase. Okay, so you're more likely to have a successful thrombectomy when you give tenecteplase. It has also shown that it has some beneficial effect on the neurovascular bundle, the brain itself and the vasculature around it. So there are few sort of what's called a pleiotropic effects of the tenecteplase alongside just the thrombectomy success. So we are looking at that. So we have extended time window up to 24 hours for large vessel occlusion. Most of these patients are thrombectomy eligible. However, there are few patients who may not be thrombectomy eligible. So we just give them tenecteplase and be done with it. And we don't take them to thrombectomy. So we are looking at, but it has to be large vessel occlusion. It can be low, small vessel occlusion such as a lacunar stroke. And I think most of you know the difference between lacunar stroke and a large vessel occlusion. I hope you do, because we have talked about it again many times. Remedy 2 trial. Remedy 2 trial is a drug, it's a neuroprotective drug trial. It is a particular kind of molecule called collectorane 1 inhibitor, and this is a synthetic form of it, recombinant form of it that we are using. This is a molecule that exists in the body, and in the past had been purified from animals and had been used in experiments and things like that. But this is a synthetic or recombinant form of the drug, and what it is supposed to do is prevent that apoptotic pathway I talked about here, where the brain just irreversibly dies, the cell dies. It is supposed to slow it down or prevent it to some extent. So we are expecting some kind of recovery or better performance of these patients compared to patients who don't get the drug. So this will be a randomized study where we'll randomize the patients getting placebo versus the drug. And it's an IV infusion first and then sub-Q infusions for a couple of weeks, 2-3 weeks I think. And then we follow them for a few months afterwards. So we'll see. The only thing with this one is that they cannot be a candidate for TPA or mechanical thrombectomy. And there's an upper bound and lower bound on the NIH stroke scale as well. So we are not taking super severe strokes, but we're not taking like an IH of 1 either. So this is somewhere in the middle, patients who have strokes, and we give them this medication and see what happens. So when are we going to start enrolling?
This week.
This week, all right. This week we're going to start enrolling.
We can start in an hour. So,
We can screen fail them. We can start screening actually, so.
Okay.
Yeah.
Sounds good. All right, so that's all the studies. What else are we going to talk about? I got 15 minutes to talk about.
Just
something.
Let's start to bed.
well,
Come on, guys.
I always like.
You can pick me any topic.
I always like,
Sorry.
go ahead.
Hello?
Any topic.
Hey, what's up?
What was the article for? What's, thing to
Yeah,
talk
sure.
about?
Give me 10 minutes. It doesn't. Okay. Yeah, sure. Yeah, sure.
Anticoagulants.
So this is supposed to be the topic of.
Hey, Sherman, what's up?
What was the one you chose?
Okay, did you go brachial or radial? Okay, I'll join you in 5 minutes. I got to where you are, Sherman, but we can talk for 5 minutes. What's up?
Okay, no, when you would use an anticoagulant versus an antiplatelet, why would you use an anticoagulant, I guess, instead of an antiplatelet when you're talking about acute stroke?
An excellent question. This too will require 2 hours, but we will try to answer this in 5 minutes. So,
Save it for the next one too.
anticoagulation
Yes.
is the indication for that is very straightforward. Cardiac arrhythmia. That's it.
And that's it?
That's it.
Okay.
Well, I shouldn't be that cavalier and say this is it, but that's the most common one, right? What are the other ones? Intracardiac thrombus. So somebody has an LV thrombus or an LA thrombus that you can actually see on the ultrasound. A mechanical valve, mitral valve or aortic mechanical valve, not a big valve or bioprosthetic, but a metallic valve. That would be an indication for it. Hypercoagulable state, such as one induced by COVID-19 infection,
Okay,
such as one, given by antiphospholipid antibody syndrome, factor V Leiden deficiency, or whatever other,
Okay.
hypercoagulable state induced by malignancy, for example. And these are all indications for anticoagulation for a stroke patient. So it has to be an embolic stroke, all right, and you have to have certain considerations for where the stroke, the clot may have come from. All right, so if you suspect cardiac or hypercoagulable state, then you put them on anticoagulation. For everything else, it's antiplatelet. And single antiplatelet, long-term dual antiplatelet is okay up to 3 months.
Okay, so, okay, what about, and I'm an old nurse, so you have to forgive me, but they used to use anticoagulation for severe stenoses too, especially posterior.
Yes. So this came out from all this Dr. Kaplan's work at Harvard, which the Massachusetts General Hospital, and the joke was back when I was training that MGH stands for must give heparin. Everybody got heparin, which we have since found out that it's not the right thing. In fact, if you have chance, you can look up the trial called WASID trial.
W-A-S-S-I-D?
Just W-A-S-I-D.
W-A-S-I-D.
WASID trial, which categorically proved that anticoagulation was not better than antiplatelets, and then we have since then rejected anticoagulation in favor of antiplatelets. So this was done for intracranial athero, like you said, posterior circulation. So this is ICAD, intracranial atherosclerotic disease.
Yep.
There's another trial called VORS trial, which was done for all-cause strokes, and this also showed that anticoagulation was not the way to go.
Okay.
There was actually a recent one that the Xarelto people did, for all ESUS trials, so embolic stroke of unknown source. ESUS, this is, so if somebody has an embolic stroke, we don't know where the clot came from. So they took all ESUS patients and put them on Xarelto, and that didn't really show much either. So people don't do it. So again, the point is people keep pushing for more blood thinner is better than less blood thinner. That's the idea goes. It's not necessarily true. More blood thinner is not necessarily better than less blood thinners. So people keep pushing, like, give them more, but all these trials keep coming back negative. So, people try to paint this with a broad brush, and you can't take a painter's brush that's like 4-inch wide. You have to take a micro brush and paint it, because everybody's different.
Yeah, I always say everybody's body's different.
Yes, and I was just talking to somebody over the weekend, and I was explaining to them that, and I don't want to use too wide of a brush for coronaries, but coronary is a much simpler thing to deal with.
Always.
Because you have, a set number of coronaries, set kind of disease, and that's about it. You're not going to get a huge variability in the coronaries,
Yeah.
Plus you have the advantage of a 12 lead. An EMS guy comes in, puts a 12 lead, you know what's going on, is it STEMI or not STEMI? You can't tell that readily for stroke patients. You don't know whether they're having a large stroke, large LVO or not, but you don't know if there's a surviving brain tissue or not. You don't know whether they're going to be eligible for TPA or thrombectomy or not. So it becomes very messy and very muddied when you're trying to treat these patients.
Okay.
So that's why it's a lot more nuanced when it comes to cerebrovascular disease, whereas other kind of vascular disease. I mean, hopefully we will untangle this as time goes, but right now it's very, very tangled.
Okay.
All right, sorry guys, I have to go to the
All right.
OR to help
Thank you.
him. He needs another pair of hands, so.